In this video, we'll talk about acute pancreatitis, which is a reversible pancreatic parenchymal injury associated with inflammation. In acute pancreatitis, there is a sudden onset of abdominal pain and abnormal elevation of pancreatic enzymes in the blood. The most common causes of acute pancreatitis is either alcohol abuse or gallstones. In this video, we are going to talk about the pathology in detail, so stay tuned till the end. So let me orient you to the pancreas anatomy first. Here is the pancreas, here is the head of the pancreas, here is the tail of the pancreas, and it kind of touch the duodenum. Here is the gallbladder, liver and the stomach, just for your reference. The pancreas plays vital role in terms of digestion. It secretes several digestive enzymes and many hormones. In acute pancreatitis, there is inflammation of the portions of the pancreas which lead to problems. In a moment, we would try to understand how the pancreatic function is abrogated due to these lesions. Now let us talk about the etiology of acute pancreatitis. One of the major cause is excessive alcohol intake. Second most common cause is basically gallstone, which can block the common bile duct, and this can also lead to pancreatitis. Now there could be traumatic injury, infection due to specific viruses like mumps, like Coxsackie virus, etc. There could be metabolic disorders that lead to pancreatitis. There could be ischemia and genetic factors that might lead to pancreatitis as well. So the etiology of the acute pancreatitis can be remembered by a nice mnemonic known as get smashed. G stands for gallstones and E stands for ethanol. These are the two major and common causes of acute pancreatitis. T stands for trauma, S stands for steroid abuse, M stands for mumps virus that can cause acute pancreatitis, A stands for autoimmune component which might lead to pancreatitis, S stands for scorpion venom, H stands for hyperlipidemia, E stands for ERCP which is a treatment procedure for pancreatitis, and D stands for drugs which has the potential to lead to the pancreatitis. Now let's talk about the clinical presentation of acute pancreatitis. So obviously there is pain in the epigastric area which can radiate towards the back as well. There is vomiting, abdominal tenderness, low-grade fever, and the patient is systemically unwell. There is also tachycardia, and the diagnosis is based on all these symptoms which we talked about, and serum amylase level is one of the common diagnostic marker in this case. So here is the pancreas. We cut a cross section of the pancreas. We can see a view like this. Here, these are the endocrine part of the pancreas. These are the exocrine part of the pancreas, which secretes digestive enzymes. Now within the exocrine part there are pancreatic acini. These acinar cells secrete several digestive enzymes which goes to the pancreatic acinar duct and gets collected and released into the proper portion of the digestive tract. Now there are zymosin granules which are present in these acinar cells, and all these enzymes which are supposed to be used for digestion are secreted in a premature or in an inactive format. Now pancreatic juice contains majorly water, but 2% of that is also enzyme, and these enzymes are pancreatic amylase, lipase, phospholipase, trypsinogen, chymotrypsinogen, carboxypeptidase, and basically procollagenase. Remember, all of these enzymes, trypsinogen which would give rise to trypsin, chymotrypsinogen which would give rise to chymotrypsin, are released in an inactive format, and that ensures that there is no damage within the internal cellular machinery. So all these things are collected in the acini, and insulin, glucagon, somatostatin can be secreted by the endocrine part of the pancreas. Now pancreatic amylase has normal function of breaking down polysaccharides into monosaccharides, and normally these pancreatic amylase is secreted into or within these acinar system. But in acute pancreatitis, when there is damage of these acinar cells, the enzymes are released into the near vicinity, which can possibly damage the overall components of the pancreas. So protease, lipase, all these kind of enzyme kind of leaks out, and they are no more in an pre-format. So now they are active. They can actually lead to problem in the overall pancreas. Basically, protease enzyme damage the cells and vasculature. Lipase enzyme can also lead to fatty necrosis of the pancreas. You can understand that each of the cells have plasma membrane, and if there is lipase, they would obviously damage the membrane of the cells. So all these enzyme leakage is a big issue in case of acute pancreatitis. So let us zoom into the acinar cell to understand what happens. But before that, at this point of time, it's quite clear that leakage of the amylase into the blood is one of the hallmark signatures in acute pancreatitis. Now, alcohol, cholecystokinin, bile acid, all of these things can lead to excessive calcium release from the internal store, which is basically the endoplasmic reticulum. The IP3 receptor allows the leakage of calcium into the cytosol. So obviously in the cytosol, calcium concentration would increase. That in turns activate the ORI1 calcium dependent calcium channel, which further increase the calcium level. So what really happens in the acinar cell is a calcium overload. Then this calcium overload can lead to the opening of mitochondrial transition pores that lead to change in the mitochondrial membrane potential. If the membrane potential is changed, ATP production is hampered, so ATP is depleted. All of these kind of factors in a combination lead to the necrosis or the death of the cells, acinar cells. So the content of the acinar cells are released in the near vicinity, causing to the further problems. So overall, the molecular pathology of acute pancreatitis involves premature trypsinogen activation, dysfunctional calcium signaling, impaired autophagy, endoplasmic reticulum stress, unfolded protein response, and overall mitochondrial dysfunction and ATP depletion. So all of these are based on latest research. Now, what is the diagnosis of acute pancreatitis? So obviously, there would be pain in the epigastric area, vomiting, and the pain can also radiate to the back. All of these are kind of like clinical symptoms, but this has to be paired with blood test for serum amylase and lipase. All of these level has to be actually elevated more than 3 times than the normal. Also, the upper abdominal USG can help in diagnosis. Basically, arterial blood gas is another good measure in this case. So overall diagnosis is twofold. One is basically the blood based test and another is imaging based test. And let's talk about the treatment options. Treatment options involve supportive care, which aims to give the pancreas rest and recover by itself. IV fluids and aggressive hydration is required. So pain management can be done typically with opioids, and antiemetics would be used for nausea and vomiting. While the supportive care is running, the goal is to treat the underlying cause. So most of the common cause of acute pancreatitis is twofold, either gallstones. So gallstones can be treated with the help of the ERCP procedure. And basically, alcohol intake is another problem. So reduction of alcohol intake is another kind of like treating the root cause. Then nutritional support has to be provided. Basically, pancreas has to be in rest. So the food has to be ingested with the help of specific ways. So there are enteral feeding paradigms which are preferred over there are other feeding paradigms which can be used called parenteral mode of feeding, which basically put the nutrient into the blood, whereas enteral feeding kind of like put the food in terms of a catheter to the portions downstream to the pancreas, such that the pancreas doesn't have to perform its job and it has its rest to perform all the recovery kind of functions. So this is how acute pancreatitis can be managed, and it is treatable based on the situation. But if it goes to chronic pancreatitis, that has bad implications. Chronic pancreatitis refers to the long-term pathological fibro-inflammatory changes in the pancreas. Two words are very important: long-term and fibro-inflammatory changes. So this particular disease is associated with fibrosis, mononuclear cell infiltration, which lead to inflammation, and oxidative stress. Also, there could be genetic components underneath chronic pancreatitis. One of the most common factor is basically CFTR gene mutation. CFTR mutation can lead to altered chloride and bicarbonate secretion into the pancreatic ducts that results in the pancreatic secretion which is more thickened, and it can obstruct the pancreatic ducts. One of the most common reason for chronic pancreatitis is long-term exposure to alcohol and cigarette smoke. There are many other reasons, but these two are the most prevalent ones. So let us talk about the hereditary pancreatitis, which might lead to the chronic pancreatitis, and this is extremely rare, but it's often often it is due to the gene mutations. One of the common factor is CFTR. CFTR maintains the chloride and bicarbonate homeostasis into the pancreatic ductal system, and in case of CFTR mutation, this homeostasis is altered, which lead to problems with pancreatic secretion and ultimately lead to chronic pancreatitis. This is only one example. There are many other mutations which are known. For example, PRSS1, which basically encodes for trypsinogen, is another gene which is often mutated in case of chronic pancreatitis. Similarly, SPINK1, which is a serine protease inhibitor, also CSIR, which is basically a calcium sensing receptor, etc., can also lead to or could be the underlying cause of chronic pancreatitis. Now let's talk about the structural changes that occurs in the pancreas due to the course of chronic pancreatitis. So one of the most common thing is basically abnormal pancreatic duct. So one can clearly understand these ducts look very swollen and abnormal, and inside those dilated ducts there are stones. There could be pseudoaneurysm and bleeding. There could be biliary obstruction, venous thrombosis, calcification of the specific portion of the pancreatic ducts. Also, there could be pseudocyst formation. All of these structural anomalies are associated with chronic pancreatitis. Now, let's talk about the pain. So there are primary and secondary reason of pain. In case of primary, the duct obstruction and tissue hypertension leads to the pain. Active inflammation is another factor which is often lead to inflammation and pain. Other than that, tissue ischemia and bunch of nervous factors like basically altered nociception because of cholecystokinin related changes in pain threshold, local nerve damage, peripheral and central nerve sensitization. All of these can lead to the pain or chronic abdominal pain in chronic pancreatitis. There are secondary pain which are associated due to local or systemic level complications. So one of the most common complications are obstruction of the bile duct, peptic ulcer due to the lack of blood flow, bacterial overgrowth due to the changes in gastric motility, small bowel strictures that happens after acute pancreatitis. All these factors can lead to severe pain in chronic pancreatitis. If you haven't yet subscribed to our channel, subscribe now. So let us now compare acute pancreatitis with the chronic pancreatitis. So in case of acute pancreatitis, we can see the pancreatic head here, pancreatic tail here. This is adjacent to the duodenum. Gallbladder is here, liver and stomach can be seen in this picture. So in case of acute pancreatitis, the digestive enzymes and basically hormonal secretion ability of the pancreas is compromised. There are localized inflammation in the pancreas. It might occur for short-term duration and might reoccur in future based on the cause. So basically the major cause of acute pancreatitis is also alcoholism, uh, biliary obstruction. There could be gallbladder stones that might lead to obstruction of the gallbladder. And basically, there could be traumatic injuries and infections, especially mumps and other viruses like Coxsackie virus can lead to acute pancreatitis. Metabolic disorders can also lead to acute pancreatitis. Alongside that, ischemia and genetic factors could be underlying acute pancreatitis. So the clinical presentation of acute pancreatitis is intense epigastric pain. Pain can radiate to the back, vomiting, abdominal tenderness, low-grade fever, tachycardia, etc. So the diagnosis is based on all these clinical symptoms and the serum amylase level. So the serum amylase would be abnormally high in this case. Let's talk about the pathophysiology of acute and chronic pancreatitis in a subsequent manner. So this is the pancreas. If we cut a cross section across it, we would see the endocrine pancreas. Here is the exocrine pancreas. So these are the acinar cells and there are the ducts. So these acinar cells has zymogen granules which are basically containing enzymes in an inactive format. Pancreatic juice is basically water and enzymes. It contains pancreatic amylase, lipase and many other enzymes. So all these things are released in the duct. Also hormones are released by the endocrine part of the pancreas. Now what happens is, in case of acute pancreatitis or injury which eventually might lead to chronic pancreatitis, there is a leakage of all these enzymes. So one of the things is basically pancreatic amylase. It breaks down polysaccharides into monosaccharides. In normal situation it is released in the ducts. But in acute pancreatitis, where there is a damage in these acinar cells, there could be release of these enzymes in a premature format, in a premature time in the near vicinity. That can damage the nearby tissue, especially proteases and lipases which are released also from these acinar cells could be quite damaging for the pancreas. And now we can understand why there is an increase in serum amylase or lipase level in case of acute pancreatitis. Now there are many other molecular factors which are associated with acute pancreatitis. Alcohol, bile acid and cholecystokinin are associated with it. All these things lead to an opening of the IP3 receptor on the endoplasmic reticulum membrane. This lead to a calcium ion increase. Eventually ORI1 channel is opened which further lead to calcium ion increase. So overall there is a calcium overload. So the molecular pathology involves a calcium overload into the acinar cells that lead to opening of the MPTP pores in the mitochondria, and that ultimately reduces the mitochondrial membrane potential. So what would happen if the mitochondrial membrane potential is altered? There would be no ATP generation. So ATP depletion is a predominant cause. All these things lead to a problem in these acinar cells, and acinar cells get damaged. They eventually undergo necrosis. Now let's talk about the overview of the molecular pathology. So basically premature trypsinogen activation, dysfunctional calcium signaling, impaired autophagy, endoplasmic reticulum stress, unfolded protein response, mitochondrial dysfunction, all of these factors in combination can be the molecular pathology of acute pancreatitis. All of these might not be present in all the patients. Now let's talk about the chronic pancreatitis. In chronic pancreatitis, what happens is there could be repetitive bouts of acute pancreatitis. In this case, what happens is basically there are stellate cells. They accumulate around these acinar cells. There could be infiltration of polymorphonuclear cells such as neutrophils. There could be also macrophage invasion. And if there is a repetitive ulcer, there would be fibrosis. So in chronic pancreatitis, fibrosis is pretty common. Hypoxia, invasion of the mononuclear cells, oxidative stress, all of these things are underlying molecular pathology of the chronic pancreatitis. So let's talk about other aspects. So duct obstruction, pancreatic duct hypertension, all of these things might lead to pain and other complications in the chronic pancreatitis. So acute pancreatitis can be detected by the basis of pancreatic amylase and pancreatic lipase levels, and obviously sometimes imaging results would also be helpful, such as USG based imaging, or also arterial blood gas measurement could be useful. But diagnosis of chronic pancreatitis is mostly dependent on imaging based studies. In this case, what happens is there is a endoscopic apparatus which is placed through the duodenum, and there is a contrast media which is filling the duct, and then it is visualized. So basically a chain of lake appearance is a characteristics of chronic pancreatitis. So one can see this particular image, it exactly depicts the chain of lake appearance. So this is known as endoscopic retrograde cholangiopancreatography, which is quite difficult to pronounce anyway, but it's known as ERCP procedure. Other imaging procedures include MRI imaging, which can show calcifications in case of chronic pancreatitis patients. You can see the red arrow depicting calcifications. Also, abdominal CT can also be an alternative for this kind of MRI imaging. It all depends on the price. Pseudocyst or calcifications can be easily detected using CT scans. Now, there are diagnostic criteria for chronic pancreatitis. So obviously there would be epigastric and abdominal pain, and there could be increase in amylase or lipase, or there might not be also increase in amylase or lipase. So that's variable part. But alongside that criteria one, either of these next criteria has to be met. Either there could be radiological imaging based evidences which would show the chain of lake appearance, or this kind of like pancreatic duct swelling and all this kind of thing. Now basically the histological proof is very rare, but sometimes when there are endoscopic biopsy happening, in that case basically histological evidences are possible to obtain. So in this case, a portion of the pancreas is taken out, sectioned, paraffin embedded and sectioned, and then imaged. And basically this looks like this. So in normal situations, these are the lobules, and you can see the duct where the asterisks are placed. Now as the disease progresses, the ducts would be dilated, and eventually there could be complete atrophy of the acinar cells, though there would be no lobules. So these are some histopathological findings, but these are the rare criteria of diagnosis. So what are the treatment of acute and chronic pancreatitis? So basically, supportive care, IV fluid for hydration, aggressive hydration is required, analgesia, basically pain management, then antiemetics, and underlying cause has to be treated. So in many of the cases, acute pancreatitis is happening due to basically gallstones, so that has to be removed. Alcohol and cigarette smoking should be totally prevented, and nutritional support should be provided. In case of chronic pancreatitis as well, lifestyle modification is the key thing. Then pain can be managed with opioids, NSAIDs, etc. But sometimes surgical intervention is really required based on the status. Then dietary management comprising low fat diet and frequent small meals, these things has to be taken care of. One of the important thing that can be done is pancreatic enzyme replacement therapy to aid the digestion process. And since the pancreas and its function is compromised in long-term chronic pancreatitis, so that might lead to development of diabetes and many other problems in the patient. So those aspects has to be managed simultaneously. So I hope this video was useful. If you like this video, give it a quick thumbs up. Don't forget to like, share and subscribe. See you in next video.